we're going to start with our first annual William G. DeLong, MD Memorial Lecture. And for those of you who don't know, Bill DeLong was certainly a mentor to me in every sense of the word. I did a fellowship with him, and without going into all the stories, he's sort of been a mentor to me throughout my career. Bill DeLong has been a strong supporter of this meeting every year, pretty much, and actually chaired a different meeting actually in Pennsylvania that was sort of led to this iteration of that meeting. So basically really started this all, as well as so many other things in the Philadelphia area in our field. Bill was actually on the faculty for this meeting. So sadly we had to, take him off the list, but we put him back on. And as Dr. DeLong would say, put it on. When he's talking about cases in the OR, it was always put it on. So Bill, you're back on. Bill was chief of orthopedics at St. Luke's for many years. I won't go through all the accolades and leadership positions that he held, but needless to say, he was pretty much a giant in the field. And, still operating, still doing cases, still taking night call, still active. He was swimming on the day that he passed, and just a mentor to me and countless others. Gave me my first job, opened doors for me, and really helped elevate my career. Here in this photo is when he had invited me up to St. Luke's to give grand rounds. And actually it was for the Marty Cohen Memorial Lecture. And with me, you can see Drs. Shikunbi and Nwachukwu, also former trainees who he had taken on as faculty at St. Luke's. And here's Bill DeLong with one of our former residents at Temple on the top left, and on the top right, giving grand rounds at Temple. And Bill DeLong, a couple of things I would also say, he was very smart, had a very good business mind, but always did the right thing, never afraid to speak out. I mean, I wouldn't say he was a firebrand, but he was never afraid to stir the pot and say what he felt was right and do what he thought was right. And actually his grand rounds topic he spoke to us about was very reflective of that. And it's really hard to mention Bill DeLong without mentioning Chris Bourne, his longtime partner, and of course can't really mention Bill DeLong without mentioning Ginny DeLong. And Ginny, actually, I invited. She is here. I can let her say a word. Hi, Ginny, are you there?
I am. Can you hear me?
Yes, welcome.
Okay. Thank you, Sakub, for inviting me to the first annual William G. DeLong Memorial Lecture. I knew you were going to dedicate the lecture this year. I was unaware until you texted me that it was going to be the first annual. So I thank you for that. I know that Bill mentored you, but I do know that he considered you one of his best colleagues. Always spoke so highly of you. And I just want to thank you and the rest of your associates for putting this on, and to thank you for this honor. I was telling my cousin about it last night, and I said it's kind of funny. We knew him from when he was 17, and no big deal. And I said I guess he was pretty good if they're doing this for him in the city. So we always knew he was good. We always knew. But this really brings it home. And my children, thank you. And I spoke with his sister as well. And they're very happy that it's going to be recorded and be able to see this. So thank you.
All right. You're welcome. And thanks for joining us. All right. With that, I'm going to turn it over now to Dr. Vilella,
Okay. So good morning, everybody. I am sitting on the second floor of my house, a place called Coral Gables in Miami, Florida. It's a little bit of a rainy day today, but I really appreciate the opportunity to be with you today. I was a Saqib Rahman and Bill DeLong Fellow at Temple from '06 to '07. And I graduated as a fellowship trained orthopedic trauma surgeon. And over the past, I'd say 10 years, my career has evolved a little bit into more of a joint surgeon than a true trauma surgeon, which sort of changes one's focus when you look at injuries. And today, what we're going to talk about is a little bit something in my career that sort of came on later and sort of refocus my treatment of stuff. And it's basically the use of distal femoral replacements in geriatric distal femoral fractures.
No, since you're our first DeLong lecturer, I think it's apropos that your practice is transitioning so much to joint surgery. Can you give us a little perspective with your training from Saqib and Dr. DeLong? Dr. DeLong was a joint surgeon as well. How that perspective kind of painted or not painted, but led you to that transition.
So I guess I should start the day I interviewed. I arrived at Temple basically at 6:30 in the morning on a Thursday, and I sat in Dr. DeLong's office, and he was talking to me about the fellowship, and he said, "You're going to come here and you're going to do all this great trauma, but hey, you're also going to do ACLs, you're also going to do total knees, total hips, you're going to do revisions." And the way it worked out is eventually when I got to Miami and I interviewed in Miami, they said, what fractures can you do? And you go through the gamut of fractures that you can do. And then I said, well, I trained with this guy, Bill DeLong, and I can also do a good knee or a good total hip. And eventually the opportunity showed itself. And that's an evolution of my career that I sort of anticipated late into my 50s. And the opportunity basically showed itself basically late in my 30s. And Dr. DeLong actually was very supportive of the transition. I cannot stress, and I'd like to repeat what Saqib said, how much Dr. DeLong meant to me, not only professionally, personally. I still hear him, his sort of raspy voice when I operate. I still hear him, and it's incredible the amount of things that he taught me or the things that he guided me towards that I sort of pass on to our residents here at the University of Miami. And on a more practical term, he sort of, just like Saqib, found me my job here at the University of Miami. So, I owe him my career here and my life, my family life here in Miami. Okay. So that's the presentation. Can we go to the next slide, please? So this is a picture, I think, of what was either the first or one of the first Philadelphia Orthopaedic Trauma Symposiums. I think this is '07. This myself on the left, wide-eyed, bushy tail. I had just graduated from fellowship. Dr. DeLong to my left, that's Saqib, also with a little bit more black hair. And to his left is Mike Serra, who eventually became my successor at Temple as a fellow. I think he's now in Texas. Next slide, please. I have no relevant financial disclosure. So I'd like to begin this, because this talk for me is sort of reminiscent of my days in Temple. What I would like to do is make it a little bit more interactive. It might be a little bit uncomfortable because of the meeting, the way the meeting's being held. But what I'd like to do is ask a couple of the attendees a couple questions. And if I could go back to the summer or fall of 2006 and get Dr. Bolabo Sukondi on the line. Is he there? He was the first intern that I worked with at Temple.
B, you're in the hot seat, buddy.
Is he there?
He might need to be unmuted, Saqib.
Okay, I'll unmute him. Give me a second.
See, B thought now that he's in charge that he's immune to this stuff. But once a junior resident, B always a junior resident. That's the problem.
He was one of the first people I met on a Tuesday at 6 o'clock in the SICU at Temple University Hospital.
All right, I found okay. All right, B.
Can you hear me, B?
He's got to unmute himself. I have to ask him to unmute himself. So he's got the prerogative.
Good morning. Can you hear me?
Can you hear? Yes. Good morning, B. How are you?
Good. Nice to see all of you.
Nice to see you, Bolavo. So let's suppose, again, let's go back to the summer and early fall of 2006. You're the intern carrying the pager at Temple University Hospital on the orthopedic trauma service. You get called about a patient who's a very active 75-year-old female. She was playing golf in the Bahamas, fell, and she got on an airplane to come to Miami because she was told she had a fractured hip. This is her x-ray. You go down to see her, and you talk to her and you tell her, well, this is what we're going to do. So what are you going to tell her, and what are you going to do for her?
You know, basically looking at this injury and evaluating her past medical history, considering her current ambulatory status, I would reveal to her that she does have what we deem as a displaced femoral neck fracture. Obviously, the recommendation at this stage in the game would be to surgically intervene, and then I would then proceed to give her her surgical options.
Which would be what?
So traditionally, once you have displacement to this degree, the options to be considered would be hemi-arthroplasty versus total hip replacement surgery.
And why would you do that?
With this degree of displacement, the thought process is that if you would fix this, the blood supply would be compromised and that it would fail. If she was very low ambulatory status with minimal demands, a hemiarthroplasty would be appropriate. More recent literature suggests that if they're highly active, total hip is probably the way to go at this point.
So what you're telling me is that you have a displaced fracture in a joint in a geriatric patient that has a high risk of nonunion, has a high risk of AVN, and you need to mobilize her faster, correct? That's what you're telling me.
That's accurate.
Okay, so next slide, please. She gets treated with a total hip, right? What an interesting concept. You treat a fracture with an arthroplasty to decrease the rate of complication and get the patient up and moving faster, okay? Next slide, please. So Bolavo, once again, I promise this will be the last time. This is an 85-year-old female that's walked in the emergency room. She sort of lives at home. She's a household ambulator, does her own cooking. She sustains a fall coming out of the shower, hurts her elbow, and she arrives in your emergency room, and it's her non-dominant arm. So what do you see, and what are you going to offer her?
Sure, appears to be highly comminuted distal humerus fracture with intra-articular extension. You mentioned that she was 85. I would assume that she has some degree of osteoporosis clinically. Once again, taking into consideration her age, biology, and activity level, one could consider fixing this injury in terms of open reduction and internal fixation. One could consider non-op, which would not be ideal. And I would say, depending on the patient's activity level pre-op, one could strongly consider this, but you in terms of operative fixation, but you need a CAT scan to really delineate all the fracture fragments. Obviously, arthroplasty is always an option also.
Right. So what you're telling me is that you have a geriatric patient with a comminuted intra-articular fracture with really bad bone that is a problem for fixation. And you're telling me that one of your options is treatment with an arthroplasty, correct?
That's accurate.
Well, again, what an interesting concept, treating an intra-articular fracture with an arthroplasty. Okay, B, thank you. I'll let you go. I think we've sort of gotten off to a good start. Next slide, please. Treatment of an intra-articular fracture with a total elbow. Next slide, please. So this is an 85-year-old woman. She walked into our emergency room. She's in the early stages of dementia. She fell at home wearing sandals in the kitchen, hurt her knee, and she arrives in the emergency room. We got called with this initial x-ray. As you can see, it's a supracondylar femur fracture. It's very comminuted. She has very osteoporotic bone. And if you look closely at the lateral, you can see impaction of the joints. This is a very difficult injury to treat. Next slide, please. So distal femoral fractures account for about 3 to 6% of all femur fractures. They have a bimodal distribution with a male to female ratio of about 33 to 67. Their incidence is 4.5 in about 100,000 adults, and about half of these fractures actually occur in patients older than 70. And as our population starts to get older, obviously the number of these fractures will start to increase. Next slide, please. So operative management in the elderly in these injuries is actually very, very challenging because you have comminution, you have poor bone quality that limits your fixation. You might have significant damage to the cartilage that already might have either deformity or pre-existing arthritis. And a lot of these patients also have either previous nails or previous total hips. Most of these patients are medically compromised and they need to mobilize rapidly. The mortality rate is actually as high as about 25% per year. And these fractures cause a significant decrease in function and quality of life. Next slide, please. So similar to geriatric hip fractures, the risk of perioperative complications and mortality is very, very high in these injuries. 18% are unable to return to their walk unaided. 26% are unable to return to the pre-injury activities of daily living. And just like in hip fractures, the patients whose surgery occurred 4 or more days after injury versus 48 hours or injury had significantly increased mortality. So the point is, just like a hip fracture, you need to get to these early. Next slide, please. So there are multiple fracture fixation techniques. We all know them, from the blade plate to the 95 DCS to pre-contoured plates and intramedullary nailing. Next slide, please. So these fractures have non-union rates of up to 20%. What that means is there's a high rate of operation, there's a high rate of hardware failure. And you're taking these patients and geriatric patients that need to mobilize faster, and you're submitting them to prolonged recovery times, and there's Can everybody hear me?
Yeah, you're good.
Okay. So osteoporotic bone is obviously less able to withstand axial and torsional bending or buttress or the buttressing of articular segments. So the fixation is actually really, really difficult. But if you think about it more long-term, the failure of fixation may actually, the salvage for it is conversion to an arthroplasty that now becomes really difficult because of the complexity, the scarring, and you had a knee that has multiple surgeries, and it becomes a lot more technically challenging. Next slide, please. So primary arthroplasty has been established for geriatric patients of the hip, the shoulder, and the elbow. They have lower rates of operation. They have higher health-related outcomes. They have better mobility. So maybe therefore, the benefits of a distal femoral replacement might actually negate the need for bone healing. They might actually decrease reoperation rate, and patients can begin immediate weight bearing and mobilization. Next slide. Most literature with regards to distal femoral replacements are basically in reconstructive non-union surgery for fixation that has already failed. The use of distal femoral replacement is less robust in the setting of acute fracture because the strict indications have not been formulated, and there is inconsistency with reporting with regards to the type of implant and the methods. Next slide, please. So what do we talk about when we talk about a distal femoral replacement? Basically, it's a rotating hinge prosthesis that replaces a large segment of the distal femur. It's used in cancer, in primary or complex total knee arthroplasty, and revision knee arthroplasty. There is no standard definition that exists detailing the amount of bone that needs to be resected, but basically the consensus is that it's proximal to the insertion of the collaterals at the supracondylar region of the femur. Next slide. Other synonyms include a megaprosthesis or an endoprosthesis, and basically, as you can see in the picture, you're replacing a significant piece of the femoral shaft, and the knee is completely replaced with a tibial component. So what are the indications that do exist? Older patient, medically stable enough to go and endure surgery and anesthesia. Severely comminuted distal femoral fractures or articular fractures, particularly C3 type fractures. You have no bone stock that limits reliable fixation with bad osteoporotic bone. You need to mobilize the patient rapidly. And usually this is best done in patients that have a really low pre-injury functional demand. What complicates sometimes is the presence of knee arthritis and pain, and you need to have really a functional extensor mechanism. So rapid mobilization, you mitigate the need for reoperation, you improve the pre-op function and return as quickly as possible. And really the way to think about this chronologically is the longevity of the patient should probably not be longer than the life of the implant. Next. So preoperative planning, history, a good history and a good physical exam. You want aggressive medical co-management and optimization with your colleagues, either from internal medicine or geriatrics. You want to order the specific implants that are usually not in stock. And this I added to the lecture because this is a very important point for me. One of my first cases, I actually had to delay it for another 48 hours because the company had brought in essentially the wrong side of the implant. The goals of this care discussion, you should have it obviously with the patient and the family. You should assess baseline ambulatory status, patient's overall health. And here in Miami, you know, we get a lot of patients transferred in, and it's important to get venous Dopplers to prevent, to diagnose DVTs if the fracture is more than 24 hours old. Next slide, please. Surgery should be performed when the patient is medically stable with an experienced surgical team. The recommendation is that the distal femoral replacement should be in the hands of a surgeon who is familiar and comfortable with the implant, in the implant technology, without really explicitly noting whether it should be, you know, a trauma guy or a joints guy. If these injuries happen to your hospital and you feel that the distal femoral replacement would be the best treatment, then obviously transfer to a treating physician and a treating institution and a treating team. Next slide, please. Close reduction and immobilization with a knee immobilizer is imperative early on to provide the patient with stability and pain relief. In terms of imaging, you want AP and lateral radiographs of the involved extremity, of the shaft and the extremity above, to look at deformity, arthritis. You do your templating and figure out if there's any leg length discrepancy that could potentially be corrected with the distal femur. As far the other important aspect of radiologic workup is obviously the CT. You want to look at the bone that is available for fixation, and you want to identify fractures in the different planes and the comminution. Now, the CT that you see on the right of the image is the axial CT of the patient that I presented early on. You can see that there's impaction of the trochlea. The trochlear piece essentially has been flipped. And if you look at it critically, there's a couple Hoffa fractures there that become difficult to manage if you really want to fix them. Next slide. This is the coronal image. Again, you can see the impaction of the trochlea. But the reason I put this image, particularly the one on the right, is look at the quality of the bone around the tibia. Now, I consider myself a relatively good surgeon, but any good surgeon will have a significant amount of difficult time getting any fixation into that bone. Next slide, please. Sagittals of the same patient. Again, you see the impaction, you see the comminution, and you see the poor quality of the bone. Next slide, please. So the type of implant is usually based on surgeon preference, your familiarity with the implant, and your or the institutional availability. If you are going to do a stemmed femur for the proximal femur, you should do a stemmed tibia. You want to use cement for osteoporotic bone for your fixation. Whether or not you choose antibiotics is surgeon specific. You want to have allograft in terms of cancellous bone or cortical bone to supplement your fixation. Some implants provide the opportunity to provide metaphyseal sleeves. This is mostly in the setting of a press fit implant. And obviously, like any other total knee, patellar resurfacing is up to the surgeon. Next slide, please. Surgical technique, pre-op antibiotics, the use of TXA. Patient should go supine with a well-padded sterile tourniquet. You make an anterior midline incision about 10 to 15 centimeters down the patella, down to the tibial tubercle. Now, the tricky part is, you know, you're used to doing all these total knees through skin that doesn't have any contusion, doesn't have a hematoma, doesn't have any bruising. So you really got to be careful making that midline incision into damaged skin. Medial parapatellar arthrotomy is if you are going to go proximally for diaphyseal excision, you should head a little bit more lateral to avoid the femoral nerve. First step is to identify the joint and start by resecting the cruciates. Next slide, please. The tricky part is the circumferential subperiosteal dissection. Basically, once you've removed what's called the articular block or the articular spool, you basically take a cob elevator or a key elevator, and you basically stick to the bone up the shaft, trying to protect the posterior structures. That's one of the scariest parts of this procedure, is just basically following the bone to make sure you're not injuring anything posteriorly. You should do a square perpendicular osteotomy above the fracture site. And the first step before doing anything, you should apply prophylactic cerclage to the femur to protect all the hoop stresses that are going to pass through that osteoporotic femur. Next slide, please. This is from tumor literature. Obviously, the resected bone or the resected fracture is reassembled on the back table, and it helps you determine early on what the size of the implant should be. And basically, the blocks of the diaphyseal component of the distal femoral replacement come in all sizes, and then you can vary and figure out which length is more appropriate. Next slide, please. The tibial cut is using an intramedullary guide. You are eventually going to use a stem, usually a minimum of 16 centimeters in length. The tibial cut is very important. You are sort of determining the joint line, so you should be aware of where the meniscal remnants or the meniscal scar are, and you should mark that on the tissue as a preliminary guide to where your tibial component should be. I prefer to ream the tibia and ream the femur at the same time. It saves time. I do it without the tourniquet to make sure that the endosteal blood supply is cooling the bone. And obviously the initial stem are left in for construct trialing. Next slide, please. So when we talk about modularity, you talk about the different body lengths. Some bodies are 20 to 10 to 5 centimeters in length. And basically what you do is you trial by measuring the leg length, looking at the soft tissue tension, in extension, in flexion. You want to evaluate the patella tracking, and basically what you do is you change sort of the sizes and the length and the width of your implant to where these parameters actually make feel more comfortable or more adequate. The other trick to this is basically you have no guide to the rotation of the femur. So the rotation really has to be adjusted according to the patella tracking. And then what I do is I mark sort of the grooves for those pieces of the modular stem. I sort of mark it on the bone using the posterior linear aspera as my guide. Next slide, please. Bone plugs are up and down the tibia for cement. You want to use appropriate cementing technique. Usually you do the tibia first, allow it to dry, then come back and do the femur. If you're feeling lucky and you have enough time, you can do both at the same time. The hinge is assembled and final balance and tracking is assessed. Really, no literature provides superiority of one implant over another, but in general, the rotating hinge platform with the stem and body modularity is preferred. The hinge platform allows you to sort of not have to be perfect on the femoral rotation, but you should still aim for proper rotation of the femoral component, and you should still aim for proper coverage of the tibial component proximally. Postoperative care, 24 hours of antibiotic prophylaxis, weight bearing immediately with passive and active range of motion and gait training. Use of walking aids is encouraged. You want to make sure that the patient has adequate disposition and discharge before they leave the hospital, and assess the patient's assistant requirements and the progression with physical therapy and their level of social and family support. Next slide. So really, when you look at the literature, most of the literature obviously is oncology literature, periprosthetic fracture revision. I really found about only 5 articles that really truly talk about distal femoral replacement in only the setting of supracondylar femur fractures. This is from Injury 2005. They compared 6 distal femoral patients with 4 patients that underwent open reduction tone fixation with a mean age of about 85, equivalent surgical times, but 5 out of the 6 distal femoral patients actually ambulated independently at discharge versus only 25% of OIF. Independent ambulation was earlier in the distal femoral replacement. They had higher Oxford knee scores, and range of motion were to 86 degrees of flexion versus 75 degrees in the ORIF group. Next slide, please. This is from CORE in 1995. 24 patients with this injury treated with a distal femoral replacement. 100% of them achieved weight bearing where it's left weight bearing is tolerated. 71% of them regained pre-fracture function. 29% on the other hand required some form of assistive device. Only one case, 4.2, required a reoperation rate, was a dislocation of the hinge. They had one superficial infection, no deep infections that required surgery, with flexion to an average of about 102 degrees. Next slide, please. This is from JBJS in 2006, 54 patients, average age of 82, with a small reoperation rate of 13.6% at 1 year, 18% at 3 years, only one deep infection. However, they did have 42% 1 year mortality. Their patients were a little older, but all patients alive at 1 year regained their pre-injury function. Next slide, please. So this is from Journal of Orthopaedic Trauma, a little bit more recent, 2016. 18 patients, average age of 77, 92% regained their pre-injury function, 7% complication rate. They had an implant survivorship in the patients that they were able to follow, about 80% at 4 years, with the range of motion of 1 to 99 degrees. The interesting part about this article is they actually had a couple of them that were open, usually over the anterior aspect where the femur comes out the quad. What they did is they had an irrigation debridement within 24 hours of injury. They had a bony resection, placement of an antibiotic spacer for a while, and then they returned within a few days for definitive distal femur once the skin had healed and the swelling had gone down. Next slide, please. This is from Journal of Arthroplasty, so our arthroplasty colleagues have looked at this too. Distal femoral replacement in patients average 81 with equivalent length. They compared it to 28 patients that underwent ORIF, more or less the same age. They had equivalent length of stay. Fracture union in those that were fixed needed about 24.2 weeks, and 3 of them actually required revision. They had 20% deep infection rate in the distal femoral group. 100% of the DFR group needed assistive devices, and 23% of the ORIF group actually ended up in a wheelchair permanently. Next slide, please. So the natural question is, what about the cost? Obviously, the cost of the implant is a big deterrent to its use. But if you look at the combined cost of the implant and the total cost of care, then sort of you might reconsider. These patients have a shorter length of stay, which costs less money. They have a faster rehab. They have a faster return to pre-injury function, which is overall less taxing on the patient's life. They have less need for revision surgery for failed fixation, which actually costs money. And really, the only way to settle this is the lifetime cost analysis in this population with this injury. Compare them one to the other. Next slide, please. So really, conclusions. Distal femoral replacement is a very reasonable treatment option in comminuted intra-articular distal femur fractures in patients that have poor bone quality that is not very good for fixation. Patients should be low demand where fast mobility and weight bearing is imperative, and you should provide them with a quick return to pre-injury function. There's a lower risk of non-union. There's a lower risk of revision surgery. Please, please, please be aware of my early lessons and get the implants in early. Talk to those reps. You should have a knowledgeable surgical team at the appropriate institution, and obviously cost for the hospital is still an issue. Last slide, please. So this is the patient in question that I've been showing you the x-rays into the CT. You can see that it's a stem tibia, that it's cemented all the way down with a good cement mantle both up the tibia and proximal femur. There's not one, but 2 cerclage wires above the proximal femur. I usually hit things very hard. In terms of the sizing, you can see that it has actually the smallest size of body of the distal femur. The only other thing I would say is there's another technical trick to this is the size of the body. If you're gonna err, you should err on the smaller side of things. Next slide, please. So this is the first post-op visit. This patient really didn't remember. As I mentioned, she was in the early stages of dementia. She came to my clinic at her 2nd week post-op, and then I saw her for the last time about 6 weeks after surgery. She really did not remember her injury and was ambulating around with a cane, moving her knee to about 110 degrees. So it's incredible how one case sort of just changes the way of the way you look at things. Next slide, please. And finally, to conclude, I ask you to please compare this picture to the one I showed initially. I'm a joint surgeon now, but there's a lot more gray hair. My beard has turned gray. The building in the background is the Teatro Marcello. That is not the Colosseum. That is actually on the other side of Rome. And this building was commissioned by Julius Caesar before he died, and it's still standing to this day. The reason I mention this is I owe my career to Bill DeLong, and my career has provided me the opportunity to do these things with my family. So I will eternally be grateful. And the last thing I'd like to say is that the young man standing to my left on the picture, he was born in Philadelphia. He was born during my fellowship. He was made in Puerto Rico, born in Philadelphia. So I have my own very special Puerto Rican. And I'm proud to report that he is actually a very, very, very rabid Eagles fan. Next slide. Thank you very much.
Excellent. And I'm going to try something out here, Nano. Did that work? Did you hear that?
No.
Okay.
What am I listening for?
I tried to give you some applause.
Okay.
Did anyone else hear it?
No, I did not.
Okay.
That was, good
I'll
try.
be trying it. I'll be trying it throughout the meeting. Anyway, thanks a lot. So much we could say about Bill DeLong. And I guess what I'll say is this is going to be an annual thing. This is the first annual, and I want to thank Nano for doing it.